Thank you for that nice introduction. Yes, my name is Yannick Ginsen, and you can hear that I speak with an accent. I am Danish. I'm actually very happy being invited to this Congress. To be honest, I come in here with a very, very old technology. If I'm now in Sweden, this technology that I'm going to present to you is 12 years old. So if you now travel to Sweden and you go into a Swedish hospital, you will see that this technology is installed in all hospitals. So that innovative, no, I cannot. But anyway, I'm going to be talking about gas and air. You might know it as Entonox. I know it as another brand name, but I have been working with that pharmaceutical for 15 years. I did work for a global company where I did travel out to a lot of hospitals, and I educated staff about safe use, climate-friendly use, and so on and so on. So that's what I'm going to be talking about. And usually when I do these things, I ask the crowd, hey, how many of you have actually inhaled Entonox yourself? And there will be a lot of women raising their hands and say, we have done it. I'm sure there will also be a lot of dads perhaps stepping in and said, we also did it. Anyway, but I'm going to do a little bit of presentation on this technology from Sweden. This is me. I am the international sales manager of Medclear. Medclear is a very, very small medtech company based in Stockholm. We don't have any salespeople flying out, doing anything like that. So we work with partners. So we have partners now set up here in UK, and they are here. So I will, invite you to visit them later to see the technology. I'm also an ICU nurse by background, and you can see that I stepped back in the uniform, of course, during the COVID-19 to support my old colleagues. So this is my background. I've been working for the global gas company for the 15 years, and then I switched over to kind of clean up after myself, right? Because for the gas company, I was basically out promoting the N2O molecule, and now I'm back in a Swedish company kind of cleaning up after myself. But that's me. And we're going to be talking about the climate effect of basically a lot of things. And this is, of course, me. I live in a place where we now need to reinforce our beaches. I live in Denmark. We're a flat country. I don't know if any one of you have ever visited Denmark. We're flat as a pancake. And we now need to reinforce all our beaches because we don't want to be overflooded from the sea. This is going to cost a lot of money. And that's back to the NHS. What is the NHS talking about? Why are they now focusing on it? It's a lot cheaper to prevent than to act, of course. This is going to cost the Danish government a lot of money, also me as taxpayer. What am I doing myself? Well, I'm in the situation where I need to separate my garbage. I do that every evening. I also, and I say I should say the bank, bought myself a hybrid car. So it's about, okay, what are we doing as individuals? But I am sure that now going back to your trust, you can do a lot of things. I will point out small things where I think you can, make an effort and do something different. This is what I'm going to be talking about. I'm going to be talking about the Nitrous Oxide Programs. I'm going to be talking about the NHS, the net zero target, collaborative approach, and what can we do together. I did hear a question to the other speakers about what does it cost. Well, I'm Danish. We like to talk about pricing. So what does it cost, Mr. Ginsen? I'll ask that question right away. This technology that I'm going to present is going to cost the NHS £3 to £5 per woman. So the technology that I do talk about is not a very costly technology. Absolutely not. I'm also that the NHS has now focused on this thing about climate actions. And you're leading. I mean, a lot of the governments are now paying attention to what is the NHS doing on it. I come from a very small country. We basically copy-paste everything that you do. So the focus is on you. And I mean, why shouldn't you do it? The National Healthcare Service in the NHS is one of the most competent organizations in the world. If we now go out to all the other companies and say, hey, your organization, what does it look like? You have a very, very strong organization. And of course you have that because, based on economy size and the education level that you have within your organization, I am sure that you can drive these climate actions. And I kind of rely on it. I come from a small country. We focus on what you do. So nitrous oxide use today is used in a very different ways depending on the settings that you use it in. So demand flow of gas is a system, of course, where you only get the gas on inhalation. I sometimes compare it to scuba dive equipment. If you're out scuba diving and you have, gas coming in a free flow system, the cylinders will run out, in 5 to 10 minutes. Demand flow means that you only get the gas on inhalation. Free flow of gas is the opposite, right? That's you get the gas all the time. And of course, free flow of gas will mean that you use a lot of gas. And that's the situation in a dental setting. You also have the program now out with a lot of dentists. They need to use free flow system because they use a nasal mask. Impossible to trigger a demand-driven system on a nasal mask. So they use a lot of gas. High ventilation patients and long procedures. Well, where do you think I would focus if I were the NHS and I would go in now and really make an effort of cleaning up after the nitrous oxide use? I would, of course, go into high flow, long procedures. I often talk to a lot of anesthetic doctors. This is not for the anesthetic doctors. Anesthetic doctors will use a lot of other pharmaceuticals, more potent pharmaceuticals. They have a higher degree of education and can do so. I never talk with the anesthetic doctors about this. I never talk with them about the technology. I basically say to the anesthetic doctors, cut off the manifold. You go over to mobile cylinders and don't use a pipe manifold for this. You use too little. So use mobile cylinders instead. Focus on the midwives. So why do we have talk? It works extremely fast, right? It's a gas. So as soon as you start to inhale this, you will see an effect. So that's why we basically have it, right? It has the rapid saturation of blood tissue, rapid rise in blood and CNS concentration, and rapid uptake. Patient receives pain relief extremely fast compared to other pharmaceuticals. And you will see that, hey, this is happening because you're using a gas. It's the same thing on immolation when you get it out of the system, right? It's not metabolized in the body, eliminated by exhalation, so it has a rapid washout. What does that do with healthcare economy? That's where we now come in and say, hey, why do you even have it? The speed of action and recovery is so fast that you can have a very fast transit time on patients. So that's what I basically talk about when I say, hey, why do you have it? You have it because it's a very, very cheap pharmaceutical to use. You have an extremely fast transit time on patients. A price example or a car example. I often, when I hear this about the CO2 footprint, I go over and say, what are you really talking about? Give me, something that I can relate to in real life. CO2 footprint of 9,000 tons. It doesn't, give me any meaning. So this is data from UK. This is your data. So you from anesthesia. Anesthesia is in 2017 was total 525,000 tons of CO2 in total. That is a lot of CO2 from just an Entonox program. We're not talking about anything else. We're talking about the Entonox program. We now focus on the midwives and say, what can we do? Because we want to focus on where we gain the most with this technology, right? So the midwives, 30% of the 520,000 tons per year, 7,000 tons per year. If we now talk about something that you can relate to in cars, let's try to calculate backwards and say, hey, what is that equal to in cars? You can see here that I have pointed out that the emission here in UK is 0.221 kilo per mile. The average car in UK drives 7,400 miles per year. If you now go back and say, if we now focus with this technology on the midwives, what are we really doing? Well, we are removing 96,000 cars every year from the road in UK on similar CO2 footprint. So that is how heavy this program comes in, that, doing what the Swedes did 12 years ago, you will see the same thing. Why did the Swedes do this 12 years ago? Of course they did it because they found exactly the same numbers as we now have in the UK. So why do midwives need nitrous oxide? Well, here in the UK, you have one of the most advanced midwife used programs to support women giving birth. I have no doubt about it. You have midwives that are just brilliant. If you go over to something else and you cut away this program for the midwives, and by the way, the US are now going into a nitrous oxide program. In 2009, 3 hospitals were offering an Internox program. Today, all maternity departments in the US are doing it. They're driven by insurance companies. They're the payers. So prices in the US is, of course, that gas and air has the average price of $250 US dollars. Epidural anesthesia cost a little bit more. And cesarean section, a lot more. So empowering the midwives with the program can really make something good for your healthcare system. What are the concerns? I come from Denmark. The concerns are, of course, 2 things, right? We have already touched this about the CO2 footprint. It's also licensed as an anesthetic gas with threshold limits for exposure. You're not supposed to do anything harmful to your workers in the hospitals. So when I travel out to Scandinavian hospitals, everybody is focused on, are they exposed themselves? So we always use closed systems, meaning that all the exhale gas is being captured and guided away from staff. Impossible to visit any Scandinavian hospital enough that they use capture system to capture the exhale gas and remove it from staff. The primary states you can use it with scavenging or good ventilation. I have never, and I really state never, I have never read a study saying good ventilation is sufficient. And just to compare all the other anesthetic gases, would you do the same with isoflurane, theoflurane? Would you rely on good ventilation, or would you say, no, we need to, of course, to collect and remove it from staff? I am sure that you would prefer a closed system. So what I see here in the UK is that you usually do this with a mouthpiece. In other countries, we use a face mask. Open inhalation systems, you don't scavenge anything. I saw a study coming out from a UK saying 85% of all maternity departments in the UK do not use scavenging, meaning that you do not collect the gas and you remove it from staff. So I would expect that the exposure to those staff members would be high. You're relying on good ventilation. And what is good ventilation? But to assist the NHS, we need minor adjustment. I will come into what are the minor adjustments. And medical technicians, you have the knowledge. You can start on this. You know that this thing about, collecting and removing will be good for the staff, right? So the NHS they're talking about that, if global healthcare was considered a country, it would be the 5th highest with regard to greenhouse emissions. So healthcare is really, really driving forwards. You have a lot of greenhouse gas coming from this sector. They're also focusing on a lot of different things. In scope 1, we're talking about the anesthetic gases, and that's the 5%. The 5% is from emissions that you control yourself, meaning buildings. You control the buildings yourself, so letting the gases, just go out the window is perhaps not the best scenario. The next slide is a secret slide. Do not take any pictures or anything like that, because it's a slide that could be perhaps a little bit embarrassing, but I think it's a very good slide to show here, where we have so many skilled technicians. A lot of the products that you see out here are, products that, of course, are for the market. What you don't see are products that are stopped because they are not, giving any sense to the healthcare system. I met such a product when I was hired by this global gas company in 2008. I was sitting, in one of those telcos with all the global people, and they were basically saying, Yannick, this product, how many can you sell to the Scandinavian hospitals? A lot of people stepped in from other countries and said, we can sell 200, we can sell 300, we can sell 500. I just began that gas company, and when they asked me, Yannick, how many can you sell in Scandinavia of that product? I said, absolutely 0. I cannot sell anything. But I got 15 years in the company, so I get, I think that message was okay. But a lot of products do not reach the market. And this is in France. We're in France in 1998. And what I did say no to was the product called a foil balloon. How many of the foil balloons can you sell in Scandinavian hospitals? I said, no, we cannot sell it. But a doctor, a brilliant doctor, and he thought that the Entonox program was a great thing for his patient. He didn't have any help from any medical technicians. He didn't have any support from any companies, but he still wanted to do the gas and air for all his patients. So he developed his own product, and that was the foil balloon. What you can see here is, of course, free flow of gas, meaning that you set the flow meter 10 liters, you have the gas coming in, runs over to the foil balloon. Why is that a good system? It's a good system for him, right? He's using a closed system, so he can now guide all the gas away from him. That's the safety for him. It's not really a good climate solution, because what does that guy need? What does this brilliant doctor need to do at the end of the day? What did he do? I have had lots of meetings with him. He went to the parking lot and emptied the gas into the parking lot, and then he went back and put the foil balloon on the wall. I think I was okay saying, hey, we cannot sell it. I don't have any healthcare professionals asking for this product, so we will not do it. But by the way, I mean, that doctor was a brilliant doctor. The program in France is now called Meopa, and they don't use this foil balloon, but he was on the track with the Entonox, and he found a solution to protect himself. When we do these guidelines on these programs, we involve a lot of stakeholders, and I think this is the missing link here, that you're missing a lot of stakeholders, meaning anesthetic, they come in with the guidelines, the medical technicians come in with guidelines, they add with their knowledge, they say, hey, this is the right way to do it, this is the wrong way to do it. We do exactly the same thing in the country where I'm from. We have guidelines, we have protocols, and they are designed by you, different stakeholders coming in with their expertise on how to do this right. So the NHS is also describing our technology and saying, hey, if we now do this, if we can actually save a lot of CO2. So we're in this report, we're mentioning they know about our technology, and we have already our technology now in several trusts. I don't know if you saw this, but Newcastle was very high on that. They went out and said, hey, we have the first baby born with zero impact to the climate. They have this device, and that is the device that we're talking about. We're talking about that if you collect the exhale gas and you bring it over to a system, we can destroy it. What we cannot do is, of course, that if you use an open system, where do we then destroy anything from? So I would encourage you as medical technicians or anything with the expertise, visit your midwives and see if they use a foil balloon. If they don't use the foil balloon, I am pretty sure that they use an open system. And that's where we need to start. Start with saying, hey, an open system is not very good for you. We have, we can solve it. We can, make the gas system for destruction. So visit the midwives, say, hey, what are you using today? And I mean, lots of you will have the knowledge about, hey, it's not really a closed system. So this is, of course, what we did. And you can see here, why is the NHS, why we're being called by a lot of anesthetists? Well, the footprint of giving birth to a baby compared to the other things that epidural is extremely high. That's the red line there, that, every time that a lady gives birth to a baby, it's equal to 245 kilos of CO2. If I now put myself in a car, it's like driving 1,500 kilometers in a car. So the footprint on this is extremely heavy, and you can do something about it. This is what it looks like. It's a very simple technology. It's innovative, I get it, but it's a very simple technology. You can split Entonox by heat. You can crack Entonox by heat. So if you now collect it, and you bring it into a technology, by heat we can destroy Entonox to being nitrogen and oxygen. And that's room air. And that's what we leave behind. So this device is to electricity by heat. We crack it to being room air. That's what this device does. What it here, of course, being an old technology, we know everything there is to know about it. So we do know that, you know, that all the gas coming in, yes, we can't destroy 99.9. We know what it sounds like. We know the kilos of CO2 that we can destroy. So everything on this technology is not new. So when you visit, you know, other companies and you see all these new things, please visit our partner here in the UK, but remember, this is not a new technology. This is something that the Swedes have done for 12 years. So, destruction of nitrous oxide, yep, all Swedish hospitals has it. It began in 2004. The first hospital in Stockholm had the technology implemented in 2004. We know the life cycle cost, and we know, you know, the life cycle assessment. When I do talk to all the other distributors out here, that's the kind of key question, right? I mean, I bought myself, or my bank bought myself, a hybrid car. What's the life cycle cost on this technology? I don't know. I really hope that the car manufacturers know. I do know that the destruction technology has now been, is so old that we know the entire CO2 footprint on it. So what can you do? Well, if you're a medtech person, you can go back and visit the Midwives and see if they're using, as I said, the foil balloon. If they're not, they're probably using an open system, meaning that all the gas are then released into the atmosphere, meaning that they risk inhaling it themselves. And of course, it's not good for the climate. So it's not good for them, it's not good for the climate. So demand valves, and I think a lot of you are hospital technicians, demand valves are not supposed to be plugged in at all time. So in the Scandinavian countries, we unplug it. We unplug those and we put a label on it. We put a label on those demand valves saying unplug after use, because the hospitals are so old in Scandinavia that they will leak. So you will have great leakage in old hospitals of just nitrous oxide going into the room because they're old. So of course I would encourage you to now visit the Midwives, put a label on and say, you know, disconnect after use. That's going to be good for our environment. What you also should know that these programs, of course, have a low cost. So please encourage the Midwives to stay in the program, but clean up, you know, what they're doing. I did talk about the price. Here I have an example, right? 6,000 women per year with support from nitrous oxide programs. Climate-friendly technology installation cost £225,000. And that's a lot. I get it. That is a lot. But in a year, 60,000 women will have used the technology. So if you now take that cost and you divide that out per lady, you will see that the nitrous oxide programs are extremely cheap to support. But they need to be made climate friendly, of course. I did say that we are here. Yes, we are. We are at booth 01. So if you have any questions or you want to see this technology in person, play around with it, well, then please, you know, visit my friends and colleagues. This is what it looks like. Thank you for the attention. Thank you.
Do we have any questions for Yannick? So there's a microphone coming. Can you just say who you are and what your question is?
Yeah, hi, my name is David and I work in as a chemical engineer and device safety at King's College, NHS. My question was, has a UK economic evaluation been done to your knowledge? So for example, getting a figure on the ROI of introducing this technology and, I don't know, maybe taking into account avoided costs like healthcare costs that the NHS then has to bear for staff if they have illnesses, lung exposure and stuff. Thank you.
Well, great question, and thank you for that, Dave. They have and they haven't. It's not a very good answer to your question, sadly. They are doing the business case, and we do have trust now engaged into the technology. But like it is in Denmark, we don't really have a pocket full of money talking about sustainability. Everybody is keen on that we need to do this, we need to join it, right? But there is not any pocket for sustainability. I have a lot of trust that dig into another pocket where they talk about staff safety. And that's a totally different pocket, but they're now talking about, hey, why should we risk exposure to our workers, right? When I'm now, in Denmark and I talk with midwives, they always say the same thing. Why should we risk exposure when it's so simple just to put an exhalation hose to the demand valve and then guide that gas away from us? It's a different pocket. It's not really a sustainability pocket, but I hope that did answer your question. A lot of focus on it. Yeah.
So what's... Put my microphone on. What's the sort of market in the UK at the moment? How many devices do you actually have out there in the marketplace?
I think we need to ask our partners, BPR Medical, on it, but I wouldn't be surprised if there are now 50.
50?
Yeah.
So there are reference sites.
Oh, yeah.
It's good in terms of the climate, it's good in terms of individuals, in terms of not breathing in the nitrous oxide. It was interesting that you said it's simple technology. I didn't know that you could split nitrous oxide into oxygen and nitrogen just by using heat.
Nope.
And one of the questions that came up in my head when you were talking about that is, if it's using 3 kilowatts of energy, that's got a carbon footprint in itself. So if you're using electricity, it's also got a cost in itself because of the cost of running something at 3 kilowatts is expensive. How does that compare to has that economic case been looked at, and in terms of carbon and cost?
And that, great question, and that's what I like about the technology. I like that it's old, right? I like that this is the first hospital that installed the technology in 2004, meaning that we can now go back and take the full life cycle cost, not in terms of money, we're talking about CO2 footprint. So we're taking, the full life cycle cost in CO2 in each and every production part that is on this technology, and we break that down and we say, hey, what's the CO2 footprint on that spare part? What's the CO2 footprint on that spare part? A lot of the technologies that see, I got myself a hybrid car. Well, we don't know that, right? It's new. This is an extremely old technology. The life cycle cost has been done both in terms of production, in terms of spare parts, in terms of everything on CO2. Yeah.
Could I have a show of hands if anybody knows that they're using closed loop systems in their maternity units? Anybody here? Nobody. But you say in Sweden, everybody.
No, I'm not saying in Sweden. I'm saying, when I did travel out to Denmark, Sweden, Norway, Finland, all these hospitals were using closed-looped systems.
So we're behind the times.
You're relying on good ventilation. I mean, that's basically what you are. You are relying on good ventilation. And I'm pretty sure that if you now start to measure, okay, what are we really, exposing staff to, you will find that ventilation might not be. And why should you rely on only ventilation when you can connect an exhalation hose and guide the gas away from staff members?
I think one of the things why people come to this conference is to learn about new innovative stuff. This may not be new to you, but I'm sure it's new to a lot of the people in our audience. And they'll take away this idea and probably go and speak to the maternity unit, speak to their managers and say, this is a good idea.
I mean, that's my key message to you, right? Is, okay, you're now participating in this brilliant congress. What can you do when you come back? Well, you can certainly go into the midwife departments and say, hey, what are you using today? And I'm pretty sure that, remember the Danish guy here talking about a foil balloon from France. That's not the idea. The idea is that you say, hey, could we connect an exhalation hose and perhaps do a better work environment for the staff? And then when you do that, it's going to be easier for us to come in with our technology and destroy it. But of course, now coming into a UK hospital where you use an open system and we come in with our device, where do we connect anything to? I mean, the full, the room is full of Entonox. We cannot connect it to anything.
Yeah, but maybe the midwives will come out much happier and more relaxed.
Yeah.
After breathing in all that nitrous oxide.
That was back to my initial question. Have you tried it yourself? You have tried it yourself, right? Because you use an open system here in the UK. So I'm sure the moms will say we used it. The dads, you got it as well. I have no doubt about it.
Thank you. Any more questions?
Question about theatres.
Sorry, can you just use the microphone?
Regarding theatres and the gas scavenging systems there, is it possible to adapt the system at the outlet, not move towards the roof where it just blows away? So, in a sense, I'm addressing the issue of nitrous oxide in theatre. So, larger system like this passes through there, so that when we release it to the outside, it's no longer nitrous oxide.
It is possible. But our catalytic, we use a catalytic process to break down the nitrogen to the nitrous oxide to nitrogen and oxygen. We work by heat. And if you put in ceofluron and isofluron into our catalyst, it will wear and tear faster. So you could say, and I did see that there are companies here where they do, the other anesthetic gases. If they can withdraw the gas, withdraw the ceofluron, isofluron before the air comes into our device, we're good to go. But this is new technology. This technology where you take the isofluron, ceofluron, this is brand new. This is something, that is now occurring and has been happening in a couple of years. Our technology is old, but we try to work together, but we're not ready for the market with that. Nope.
Okay, thank you very much, Yannick.
Thank you.